And thank you so much. And we will discuss what are their respective preference, choice, and I hope we'll have also interaction with the audience because there is a lot of interest about non-invasive respiratory support, and I suppose to continue the preceding presentation, we'll speak a little bit about COVID because it has been used so much and be found to be so useful. But there are many possibilities, and I think the expertise of each site and each practitioner is something important. So I'd like maybe to start with having the panel introducing themselves, and maybe in one or two words saying what type of patients you preferentially treat, if it's a case. Gavin, you want to start?
Yes, I have to start. My name's Gavin Perkins. I'm a critical care physician based at University Hospitals in Birmingham and academic at the University of Warwick. I work in a general intensive care unit. We receive general medical and general surgical patients, so that's the general type of patients that I treat in my practice.
Thank you. Lise?
My name is Lise Piquilloud. I'm an ICU physician. I work in Lausanne, Switzerland, in a medico-surgical ICU, taking care of all types of patients, and especially also of post-surgical patients after cardiac surgery and lung transplant.
I am Massimo Antonelli. I work in Rome at the Catholic University and Policlinico Gemelli University Hospital. I'm an intensivist, and we treat large body of hypoxemic patients mostly. We don't treat in general COPD patients with acute exacerbation. So a large part of our patients are post-trauma, surgical or medical patients.
Good evening, I'm Alexandre Demoule. So I'm an intensivist in Paris, La Pitié-Salpêtrière Hospital, and scientist in Sorbonne University. And I'm working in a medical ICU, so I'm mostly treating medical patients, certain patients with acute and chronic respiratory failure and de novo acute respiratory failure.
Okay, thank you very much. I'm not going to ask everybody in the audience, but please, when you have to speak, it will be interesting to know where you come from. And so, as I said, the preceding presentation was about COVID, so I'm really tempted to start with COVID and to say, how did you treat your patients with non-invasive respiratory support with COVID? And did it change over time during the pandemic? Maybe not the very early phase where there was so much questioning about risk and safety, but as soon as you started to see this surge of patients, and what type of techniques did you use? Maybe I start now with Alex, is okay?
Thank you. So now, excluding the early phase where everyone was scared by contamination and we didn't use that much non-invasive technique, we, in my unit, mostly used high-flow oxygen as non-invasive therapy to prevent intubation, and we also used CPAP. It's a complete. So the question, obviously, Laurent, is why we didn't use non-invasive, maybe, or
oh, sure, yeah. Right.
Because we are not very familiar with the use of non-invasive in de novo acute hypoxemic respiratory failure. I think Massimo Antonelli is probably the expert of this topic. We are not very familiar with it, and because we are not very familiar with, or we are always scared of causing ventilator-induced lung injury, a reason why we prefer avoiding this risk with sticking to high flow. And because what is very important to me with non-invasive technique is to be very familiar of one technique, and all your team has to be familiar of at least one technique. And I encourage people not to be too much creative. Because if you are using 3, 4 techniques and all the team is not very familiar with, it's risky.
Thank you very much, Alex. It's very useful. And just I'm going to ask that to other also. When we had the surge of patients, we had patients in the ICU, we opened new ICU, we had patients on the floor. And so did you choose a specific technique for patients out of the ICU, or was there a difference?
No, we very quickly, we use the same techniques for patients outside the ICU, inside the ICU, for many reasons, but one of the reasons was the ICU team was training the people of the new ICUs opening, so we wanted everyone to use the same technique, so it was high flow and CPAP.
Okay, thank you. Massimo, you did not come with a helmet, but maybe you're going to discuss
Unfortunately. That. No, we share the same experience because in a way or another, we try to prevent any form of intubation by starting with a high-flow oxygen therapy. The surge of the pandemic obliged us, as Laurent mentioned, to treat this patient also outside the ICU, but as it happened in France, we train people who were not specialists in intensive care in adopting certain strategies, preferentially all non-invasive strategies outside the ICU, such as the high flow or the CPAP. However, over the time, we developed a sort of algorithm in treating these de novo patients. I do not know if this is the right way to go, but what we have done, we were discussing before this session with some friends, that in general we started at the beginning by adopting the high-flow oxygen therapy. Then we asked the patient to assume the prone positioning, we own spontaneous breathing, if the expiratory exchange worsened. If this was not enough, we started or CPAP or preferentially the non-invasive ventilation through the helmet, also because to incentivize the tolerance of the patients. We, to some extent, place some patients on the helmet non-invasive prone. However, if it didn't work, we intubate these patients, we put them prone if necessary, and ultimately, I would say in a minority of cases, but considerably higher than the usual number of ECMO patients we put during the year, we treat with the ECMO. And also put in prone positioning with the ECMO. So this was our potential algorithm. Again, there is no demonstration that it works and is the right way to go. This is what we have done.
Thank you. Lise?
We've also used quite a lot high flow, at least for the second wave, because in the very initial phase, we were very prone to intubate the patients because we were afraid of delayed intubation and of the contamination of the medical personnel and nurses. But after that, we've used quite a lot high flow in the ICU. We had the chance not to have patients, severe patients outside the ICU, then we were in the ICU. But it's not a white and black answer, because even with high flow, there can be a risk of having patient self-inflicted lung injury, especially with those patients who keep with respiratory distress under high flow therapy. And along the pandemic, our practice have changed a bit, and especially with those patients who were often obese and had some part of atelectasis, we've then combined high flow and CPAP to try to treat atelectasis with sometimes quite good results. And it was the final approach at the end of the third, fourth, or fifth wave. But one other important point to address is that whether you use high flow, CPAP, NIV, helmet, sometimes it fails, and we should not delay intubation for a too long time.
Very important message.
Okay, great. Thank you. Gavin?
So in our centre, similar to yours, in the first wave, we were quite resource constrained, both in terms of physical space in our intensive care and wards, and we tended to go for invasive ventilation, certainly towards the start. We were commissioned by our Department for Health to establish the Recovery Respiratory Support Trials. So as one of the lead hospitals, that then became the clinical pathway for patients who were requiring more than 40% oxygen and had an SpO2 of less than 94%. They were put forward to randomisation to either CPAP or high-flow nasal oxygenation, and that then formed our clinical pathway, certainly through the remainder of the first and second wave.
And would you say you changed your practice after that, after the trial?
So we changed our practices. Typically, we didn't provide CPAP or high flow in the ward-based environment, and we would be cautious about doing it in the intensive care for patients with severe acute respiratory failure.
I think you all mentioned CPAP, right? Which was not so much used in hypoxemic respiratory failure. I think it was used frequently in post-operative conditions, things like that, and of course cardiogenic pulmonary edema. There is always a bit of what kind of equipment should we use for CPAP? You have different type of CPAP. You can use an ICU ventilator, but you can also use much simpler system. Can you briefly describe which systems you used?
So I think it's dependent on the resources that are available to you, and we were very short of resources at the start of the trial. We had a ventilator challenge where Mervyn, the government, got people to start making ventilators, and Mervyn Singer, and I think it was Mercedes, developed a very simple CPAP device. So certainly that became the standard of care for our CPAP early on, because most of the other machines, which we were quite limited with, would be reserved for patients coming out the other end if we'd liberated them from ventilation.
Okay, Mercedes CPAP looks good, but Lise?
Yeah, and this is an important point for the future, because we've done CPAP with our ICU ventilators, but some of them are not very good to deliver CPAP, and patients are not very comfortable with some of the ventilators, which basically do not deliver true CPAP, but always a small amount of pressure support for some brands. And then you have synchronization problems, as if you had NIV. Then if I could choose, I would choose the simplest way of delivering CPAP with the bag.
I don't want to be provocative, but there is another way to use the ICU ventilators. Most of them do have the high-flow oxygen therapy option. Then we can, for example, connect to the high-flow source an helmet, and on the other port of the helmet, we put a PEEP valve. It works because it delivers an adequate flow rate. At the same time, you can just adjust the PEEP depending upon the need of that patient.
Okay, thanks.
As long as you keep enough flow to wash out the carbon dioxide.
This is the premise.
Yeah, so the surge, COVID surge was so catastrophic in Paris, less than in northern Italy, but so catastrophic that we keep ICU ventilators for intubated patients. And then what was interesting with CPAP is that we could use the home ventilators for CPAP. So we called all the companies with the home ventilators and use those home ventilators for CPAP. And we have all those devices like the Buciniac device, which is quite cheap. And this was, I think that this is one of the reasons why CPAP reborn during the pandemics, is that facing this catastrophic surge and we were missing ventilators, we had the opportunity to rediscover CPAP with all its advantages. I would add that if we compare all the non-invasive treatments that are available, CPAP is probably one that is really frugal and that can be used all over the world because it doesn't need so much oxygen, it doesn't need a very like technically achieved ventilator, I would say.
Okay, thank you. So a lot of high flow first, and then CPAP, and some specialized center comfortable with non-invasive ventilation, dedicated technique used it, but that was certainly not the NIV was certainly not the first approach. Anyone in the audience wants to share different or same experience? Who used mostly CPAP? Okay, not that many. Who use mostly high flow? Yes, I'm sure the company doing high flow systems are very happy. And who use mostly non-invasive ventilation? Okay, interesting. No, what's interesting from looking at the literature, and especially I think Alex and Lise mentioned that we don't know very well how beneficial is non-invasive ventilation in hypoxemic respiratory failure. We know there are risks in some categories of patients. But if we look at everything which has been tested during COVID, it seems that everything works. Works for what? Works for intubation, at least avoiding intubations. That's very clear. You have randomized trial with high flow, with CPAP for sure, with non-invasive ventilation, with the helmet. I don't think we have seen change in survival, but if you can have the patient surviving without being intubated, I think everybody, including the patient, should be happy. So, any other experience? Alex, I think sorry, yeah, please. If you can open the microphone, identify yourself.
Do I have to wake up or to?
No.
Okay,
be relaxed.
Okay, I'm coming from Serbia, from Institute for Pulmonary Diseases, and I don't want to share any experience. It's very similar, maybe with others, but I would like to ask Professor Antonelli what he thinks about the NIV-dedicated ventilators and ICU ventilators in everyday practice. What would you suggest? For example, for some respiratory unit, high dependency unit, what would you prefer to have in your unit? And to treat the patients with non-invasive ventilation, for example, with COPD, acute exacerbation of COPD, or acute respiratory failure.
Are you asking about the brand?
No brand, no.
No
brand, no. I'm asking about the difference between NIV-dedicated ventilators and the big ICU ventilators. Because
I guess that if you look at the so-called improperly home ventilator, nowadays they are so performant to be substantially comparable to the high-level ICU ventilators. So it depends on how accustomed you are, or how confident and familiar you are with one of other type of ventilators. In the ICU, for many different reasons, also because do have a number of intubated patients, we prefer the common and modern ICU ventilators that can deliver also the non-invasive ventilation with the compensation of leaks. In other settings, including the pulmonary step-down units, the ventilator, the non-ICU ventilator, let's call them that way, are perfectly suitable, in my opinion.
Okay, thank you.
Maybe you mentioned COPD. Do you want to discuss briefly what you do for exacerbation of COPD, or let's say exacerbation of chronic respiratory, hypercapnic respiratory failure? Yeah, maybe Alex, you want to?
Right, so for acute and chronic respiratory failure, let's call this like, we use non-invasive. And so we use non-invasive. This is, I would say that this is one of the treatments in the ICU that is shown to decrease intubation and to decrease mortality. Actually, there's not so many treatments in the ICU that have been shown to decrease mortality, and this is one of those. So we use non-invasive for acute and chronic respiratory failure. So the question is, do we use high flow between non-invasive sessions? And the answer is no. We do purely non-invasive.
So Massimo, you don't treat COPD, so...
Not in general, but in the first aid. And this is as the guidelines recommend, this is the first choice treatment for these patients. To be honest, even though are not so many those I treat, the vast majority of them, as soon as are approached through the non-invasive ventilation, may even resolve the acute illness and may be moved from the emergency to the medical ward, for instance, in a few hours.
Yeah, many of these patients are treated in the emergency ward before, right? Lise?
Regarding the COPD, maybe that in our practice, we have to actively fight against high flow instead of NIV. Yeah. Because at least in my unit, sometimes in the morning, with an acute exacerbation of COPD, I find the patient under high flow, and when we ask why, people answer, because it was easier. And this has not been demonstrated. NIV reduces mortality in COPD exacerbation. For the moment at least, not high flow.
Gavin?
So, yeah, we would use non-invasive ventilation. If the respiratory acidosis isn't too bad, that will be done on the ward. They'd be triaged off to our respiratory ward. If they have a more severe acidosis, then we bring them through to the intensive care unit, put an arterial line in where we can monitor them more closely.
Great. Who? No. Yes, sorry. No, go ahead.
Now, one important point that has been mentioned but not enough stressed is timing. We often, during the pandemic, saw patients that were lately centralized and who received non-invasive ventilation or in any forms, including CPAP, for too many days. And so when they arrived into the referral ICU, they indeed were in very poor condition and we were obliged an emergency intubation. So be very careful.
Okay, thank you. Who is in the audience who would typically start high flow for treating, and I'm not judging whether it's good or bad, right? Treating a patient with COPD. Come on. I agree with Lise. That's very easy. I mean, in the emerge, they tend to do that, right? So. Oh, I see my friend and colleague Nutapol Ritayama. He was maybe not expecting to be, but you've done one of the very few studies on high flow and COPD and in Bangkok. And what's your experience? Can you comment?
For this question, I still agree with Liz that we should start first with the NIV. However, we have more evidence that high flow may have some physiologic benefits in hypercapnia. So maybe between the NIV sessions, or if patient could not tolerate NIV, I think we can choose a high flow, but we still need more data in terms of the clinical outcome wrong.
Thank you. Because what was interesting in your study was that it seemed that it was open and that when you increase the flow to up to 50 or 60, the effect was less obvious and maybe even some patients increased their work of breathing, right?
Yes, in that study, we titrate up the flow from 10 to 50 liters per minute, and we found that when we increased the flow to the 50, patient felt uncomfortable and higher work of breathing compared with the mid flow around 30 to 40 liters per minute. Yeah.
Great. So we mentioned patients with hypercapnic respiratory failure. My impression from the different places where I've worked is that it's not anymore the typical COPD we were seeing 30 years ago. And we are seeing patients with mixed disease, some cardiac dysfunction, obesity, etc. And sometimes we say COPD, but they have no COPD at all. And I found that, and sleep problems and obstructive sleep apnea. So I found it a bit more difficult to define the best ventilation technique. I would say obesity is more and more prevalent. And so I'd like to know how you deal with that, whether it's all the same or you have a different individualized approach.
Yeah, to me, it's all the same at the early phase, because all the diseases you mentioned are very responsive to non-invasive. Because you said obesity, and data on non-invasive in obesity show that obese patient with obesity syndrome, in English, yes, hypoventilation, obesity hypoventilation syndrome, that those patients respond even better to non-invasive than COPD patients. You mentioned cardiac failure, and there's a strong evidence showing that CPAP and non-invasive are efficient in cardiac failure. And you mentioned also sleep apnea, and we know that CPAP is beneficial. So I think that this is the reason why we consider non-invasive as a first-line treatment for all these patients, because it's efficient in all these diseases. To me, the challenge is after, because as you said, the profile of patient is changing, and what is important is that once we have been successful with non-invasive and the patient is moved to the respiratory ward, then the appropriate examination of the patient is done and his disease is classified, because otherwise we see what we are seeing more and more is the patient being readmitted in the ICU very frequently, probably because the disease, his or her disease has not been fully understood and the appropriate treatment have not been initiated.
Thanks. Massimo?
I totally share the view. I must say that in large part, as you mentioned, both of you mentioned, we treat obese patients quite efficiently, but once again, if you have a patient who is hypercarbic, who has the label of COPD but does have a cardiac failure, of course, it works because there is the cardiac failure and cardiogenic pulmonary edema, for example.
Okay. Lise, any comment? Gavin?
No, much the same. I think when they present with hypercapnia, non-invasive ventilation is it would be my go-to treatment.
Any other approaches? I have to say I disagree with these guys. No, I disagree, but I don't know what to do. I disagree because, you know, patients treated with severe sleep apnea syndrome, right? They have CPAP at home. Do you know how much CPAP they have? 6? 10? Sometimes it's 20, 25. At home, they need 20, 25 to keep their airway open. And we give a PEEP of 6 when they are in acute exacerbation. I don't think we are doing well, honestly. So I'm very cautious when I see really patients known for severe apnea syndromes or very obese patients. I tend to put the PEEP much higher. Whereas in COPD, I put the PEEP as low as possible. I don't think we see so many patients with high intrinsic PEEP. But that's my personal opinion. I think we need to put everybody in the same bag, and I'm not sure we do the best for them. So, yes, please.
Does the panel use any respiratory monitoring in their patients on NIV?
Okay, what respiratory monitoring?
So I think the patients I look after will be typically in the intensive care unit, and so they'll be monitored with pulse oximetry, ECG, and they'll almost invariably have an arterial line in, purely so that we're not having to undertake arterial blood gases sequentially in them. Out on the ward, I think the monitoring in our setting is limited to pulse oximetry and then intermittent blood gases.
But there's been like reference to patient self-inflicted lung injury or the dysynchrony? Do you have any specific monitoring for that, or is it just the end of the bed impression?
Very good question. Unfortunately, it's complicated, as you know, to put advanced monitoring system, especially esophageal pressure. But based on the clinical evaluation, you already have an idea of the work of breathing, and looking at the ventilator curves and airway flow curves, you can already improve synchrony. And this is, in my opinion, one argument to use advanced ICU ventilators to treat those patients, because you have much better curves on the screen.
At times, monitoring may be problematic, especially if you use the helmet, because as you know, you cannot really rely upon the tidal volume that you can see on the screen, because it's the sum of the tidal volume delivered to the patient and to the system. So under these circumstances, not having at the bedside any available method, you should use some research methodologies. One good point for acute patient is use also the esophageal catheter that allows us to know at least what is the transpulmonary pressure, and in this case prevent the idea that the patient may deteriorate also because there is high transpulmonary pressure that unfortunately cannot allow the continuation of non-invasive ventilation through the helmet.
Do you use esophageal pressure in the acute settings, not for research, right?
No. Yes, we do.
In the non-intubated patient?
In non-intubated patient.
Okay.
So we, for acute and chronic respiratory failure, only for respiratory, respiratory monitoring, we keep it very simple. Respiratory rate. Expiratory tidal volume is essential. This is very important because we know that if expiratory tidal volume is not enough, we do not clear CO2, so the patient remain acidotic. So and some blood gas, but not too much because it's painful. One blood gas after the 2 first hours of non-invasive, and then one in the following morning, for instance. But not too much, not too many. And we don't do advanced monitoring such as esophageal pressure in non-intubated patients because we're not familiar with, and I think we should do what we're familiar with.
I would like just to add a point to clarify. We give enteral feeding to all our patients, especially during the first few days when there is an acute phase. And under these circumstances, using NG tube or NG tube with a esophageal pressure doesn't make a major difference in terms of tolerance. That is why we're using that.
Anybody using a CO2 signal, either end-tidal or even transcutaneous CO2? You use that?
Yeah, we have some experience with the transcutaneous system in the majority of the patient when there is no hemodynamic compromise. In my experience, it works quite well, but not in all. Then always check the gradient.
We don't.
Okay. I feel the transcutaneous is working much better than we think, but it's still much more complicated to put in place than compared to the simple oximeter, right? Any other?
Can
yes,
I ask?
Oh, sorry. Yeah. Sorry, where is it? The lady was.
Yes. Can I ask if any of the panel have any advice on minimal sedation for those patients who may not tolerate it in form of low-dose opioids infusion?
I'm not sure we're going to reach a strong agreement on this. We do not do, once again, for acute and chronic respiratory failure, we do not do sedation. If the patient doesn't tolerate non-invasive, we don't give non-invasive. Because basically, non-invasive was proved to be efficient in patients who accept non-invasive. So we think that because we are not, once again, we are not familiar with sedation in non-intubated patients. We are not familiar with, the team is not familiar with. We are afraid that there's a risk of worsening the patient to give the treatment to the patient. So first we worsen the patient, then we give the treatment. This is what we fear. So we have decided not to give sedation, and if the patient doesn't want non-invasive or doesn't tolerate non-invasive, we don't give non-invasive. But it's only what we do.
I have the same strategy as Professor Demoule, very careful with sedation. And what I would like to add is be careful with the opioids, because the opioids tend to decrease respiratory rate, but to increase the strength of the contraction, to maintain minute ventilation, and maybe there is a risk of increasing patient self-inflicted lung injury if we put continuous infusion especially of opiates. Then we should be careful.
And I think we don't protocolize the use of sedatives or analgesics, but I think, as you say, if we are going to use it, which is in an intensive care setting, then we'll do so carefully in the event that it will enable a patient to settle onto non-invasive therapy, as opposed to us sedating someone for a prolonged period in order to tolerate the non-invasive ventilation.
Maybe can I ask the audience who would use any form of sedation in an hypercapnic patient? Not much. I think you're scratching your head. And in an hypoxemic patient, who would use any form of sedation? A bit more? Yeah. Okay. I think there was a question in the back, right?
Yes, Davide Colombo from Italy. I work in a general ICU. And earlier the panel underlined the importance of the timing of non-invasive ventilation and intubation. I think that this is one of the most crucial points. And I would like to have your opinion about a patient affected by de novo hypoxemic respiratory failure. You started with CPAP. The gas is increasing a little bit, but the patient developed a pattern that is suspected from self-induction lung injury. I mean, high volume, and he is in stress. Is there room to move this patient to
What do you
NIV?
mean is in stress? What do you mean?
Dyspnea.
Okay.
He say, I am in stress. And there is room to support this patient with some pressure support, or it's time to intubate?
Okay, good question.
Very good question. What we have done, just to compare the action of CPAP, non-invasive ventilation, and the high-flow oxygen therapy, looking at the response of the physiological variables. By using the non-invasive ventilation, there are two different categories of patients. Those who may reduce the inspiratory effort by applying a pressure support, and those who don't. And this is a very important difference, because for those who doesn't, for those who don't, at the very end, the only solution is the intubation, of course.
And your patient is a very good candidate for esophageal catheter if you have it.
Yes.
Then you can demonstrate.
There's a few data suggesting that patients who remain dyspneic, severely dyspneic, I would say more than 4 on a scale from 0 to 10, under non-invasive, are at high risk of being intubated. And this is especially the case in COVID patients, because it's a disease where dyspnea is not very intense. So to me, a patient, COVID patient, saying, I can breathe with a dyspnea of 5 or 6 on a scale from 0 to 10, high respiratory rates and labeled breathing, in general, we're gonna intubate the patients. So why waiting too long?
So Alex, would you, because you're both talking of patient feeling dyspneic, would you recommend to do that more formally, rigorously, like a dyspnea scale, or?
Yes, yes, I would. Yes, this is what we are doing actually now. Of course, because we're working on this topic, but also because we feel that it's important to monitor dyspnea for many reasons. It's a good indicator. The absence of improvement of dyspnea in response to the treatments is a quite good marker of the inefficacy of the treatments. And in addition, it raises a question. I mean, a patient with a pain of 5 on a scale from 0 to 10, we treat it. And with dyspnea, it's a question, it's an open question, but in dyspnea, we tolerate patients with 5 or 6 sometimes, and we don't do anything. It's a problem.
So what would you do with a patient with a dyspnea of 6 or 7?
I'm pretty embarrassed, so it depends. If the patient is not intubated, in general, this is a patient who will fail the non-invasive technique, whatever. Yeah. So I think it's a good criteria for intubation.
Because the best pharmacological treatment we have for dyspnea is opioids now, but we heard it's not that great. Okay. So maybe just to continue the question, there are 2 questions, right? One is, what is your strategy for escalation? What's the next technique and when do you stop? And then the final question, when do you intubate, right? So you touch on it, saying the patient does not improve dyspnea or effort, but we don't really measure the effort. So escalation maybe Gavin, and then when you decide to intubate.
So in terms of escalation, and I guess, typically in my intensive care, we're using, CPAP. I may escalate to non-invasive ventilation, but then after that, it will be to invasive mechanical ventilation. And in terms of So
most of the patients not doing well with CPAP, you try non-invasive?
Might consider non-invasive.
Okay.
I guess it would depend in the context as to how well the patient was settling, and then probably a combination of physiological measurements in terms of heart rate, blood pressure, physical appearance of the patient, dyspnea, sweating, accessory muscle use, and then serial measurement of arterial blood gases, and taking those together. It's in most patients it's easy to see that they're on a pathway to resolution, a pathway where they're stable, or a pathway where they're deteriorating despite treatment.
Please, escalation and when you intubate?
Escalation to NIV, usually not. Escalation to CPAP, yes, if I think that my patient can answer to a reopening part of the dependent lung.
Sorry, you mean high flow
high
to
flow
CPAP?
To CPAP, yeah. Then intubation, of course, the most difficult question of our daily practice. Then I think we should trust on clinical evaluation, respiratory distress sign, dyspnea, and for those patients who stay dependent for very high FiO2 under high flow and who are dyspneic, we probably should intubate them quite early. And maybe we have part of the answer when we look at the results during the pandemic, because during the first wave, nearly all of us had early criteria for intubation. And then they moved further and further, and we had patients for a very long time under high flow or CPAP or high flow and CPAP. And in the most of our units, the results of the second and third wave are worse in terms of mortality compared to the first wave. Of course, there are a lot of potential explanations, but maybe included delayed intubation. At least in my patients, I think it was part of the explanation.
I guess that all agree, as soon as you have dyspnea or the PF doesn't improve over the first few hours, and other clinical clues are important. However, I would make also another point. It depends on the device you're using, and it depends on the level of monitoring. I elucidate what I mean. if you're using the mask non-invasive ventilation, you can monitor easily the volume. If you see that the volume is kept very high, it has been demonstrated by the French study that they are more prone to fail, and probably you need to be very ready for the intubation. Or when you measure, which
Massimo, you say very high. Can you be more specific?
Okay, let's say roughly above 700 milliliters or something like, but it's very generical, and you should adapt to every single patient somehow. High volumes are indicators of failures. And another possibility, which is the alter ego, let's say, of the high tidal volume, is the esophageal catheter. You have placed it, you can measure the transpulmonary pressure, the inspiratory swing, and then predict the possibility that the patient is going to fail, and intubate them promptly.
Okay, just to say, when you mention tidal volume, you need to measure it, right? So, and it's only if you have a ventilator who can measure the expired tidal volume that you can do it.
So regarding escalation, I have to admit that, so we do mostly, so we're talking about de novo acute hypoxemic, so no, that's the question. So I have to admit that during the COVID, we were doing high flow and escalating with CPAP. We are not escalating anymore that much. So there is no more COVID, and so we do high flow. And we sometimes escalate with CPAP in obese patients, I would say. But we don't using CPAP as much as we were using CPAP during the pandemics. So regarding criteria, I think that we all agree it's very difficult to decide when to intubate a patient. Actually, if you put 2-3 clinicians in front of a patient with acute respiratory failure, they are not going to agree. They're going to, in general, disagree, or they're going to agree, and one will change his mind, and then the two other one will change their mind. And so it's very difficult to reach a good agreement, I would say. But to me, a patient who's not responding to the treatment, whether it's the signs of labored breathing, oxygenation, of course, dyspnea, even a little bit respiratory rate, I would say also, these patients, we tend to intubate these patients if they don't respond, if they don't improve.
Okay, thank you. There is a question, yeah?
Hello, Busana from University of Göttingen. I have two considerations. One's regarding monitoring, and the other one regarding to escalation. So first, the monitoring we were using we've been using during the pandemic, and still now I have to say a lot, the esophageal balloon and also non-invasive tidal volume monitoring, let's say. It's impressive when you're also an awake patient, when you are measuring with the esophageal balloon the transesophageal pressure, you might see driving pressures of 25, 30, 35. And the nurses, is incredible how they are able to tell you that a patient with invasive mechanical ventilation with 15 of driving pressure, they tell you, well, we need to do something for that. But no one cares when a patient is awake without tube, has 30, 40 of driving pressure. And I think it's extremely important, because when you don't see the numbers, you think that the patients are not sick. You don't measure pulse oximetry, and you don't see that the patients are hypoxemic. You don't measure driving pressure, so the patients are not doing self-inflicted lung injury. And the non-invasive tidal volume monitoring, I find it's so non-invasive that we should do that more and more. I don't know if it's reliable. I'm doing some analysis on that, but it's also impressive to see patients that are not intubated, that have 20, 25, 30 liters per minute. Would we ever accept that number in invasively mechanical ventilated patients? Then after we need to understand if positive pressure and negative pressure with the same setup are equally damaging. That's a totally different question. And the second thing about escalation, we are finding ourselves more and more, always with COVID, to skip altogether the intubation and go directly to awake ECMO. that I understand it's quite, indications for ECMO are already limited, so indications for awake ECMO are even more limited. But I don't know, when you see a patient with 85% of saturation and 28 of PCO2, yeah, then you need really to consider to intubate him because he could really die on the induction.
Okay, thank you for these comments. Just wanted to mention, because we are discussing of the risk of non-intubating patients, right, and keeping them too long. Just on the opposite, the initial first phase of COVID, at the time where we intubated a lot of patients, we didn't know, right? There are quite strong data saying that the mortality was extremely high because of intubation. So I think it's good to try to avoid intubation, and the discussion is when to stop, right? When the patient is at risk, which is a very difficult one, tricky one, for which we may need more monitoring. Yes, please. Identify yourself and your...
Yeah, I'm Dr. Samizo from India. We had unfortunately huge number of patients, being a population of 1.4 billion. You can imagine in a wave how many patients you can get admitted in the ICU. In April 2021, somewhere around 20th April, we had 80 patients who were intubated in ICU, and another 40 or 45 patients who had a PF ratio below 100. And all the 40 patients were treated with HFNO or NIV because they just had no opportunity to get invasive mechanical ventilation. And this situation happened in almost all hospitals in our city. So we collected the data of almost 1,200 patients, of such patients who were treated electively or by compulsion with non-invasive ventilation or HFNO. And it was published in Indian Journal of Critical Care Medicine. So we found that even with severe ARDS patient in whom PF ratio was below 100, almost 40% patients survived with HFNO and NIV. And surprisingly, those who ultimately got intubated, almost 85 to 87% patient died.
So maybe because we have only 2 minutes and I know the poster session are going to start. Do you think, let's say in India, you are well prepared for the next pandemic?
I don't know what is your definition of well prepared, but if it happens...
I mean, in the context of we have so many risk again of seeing new respiratory infections, we know that we need non-invasive techniques.
Yeah, but definitely we are much enlightened with the non-invasive techniques because of the COVID, and we stretch to the limit because not out of choice, but out of compulsion.
What do you think?
So I think just reflecting back to your original comment about the link between invasive ventilation and worse mortality, that I think the story is complex because, of course, at the start we were overwhelmed. Certainly in the UK, and I know a number of other places, we were having to bring non-specialists in to look after patients in intensive care. What became really difficult in the second and third wave, because it absolutely became a narrative that if you go on the ventilator it kills you, it is that we would have large numbers of patients that even at the point that they required invasive ventilation because they'd failed CPAP, that they were refusing invasive ventilation because the word in the community had got out, that it would kill you. So I think, the messaging, we need to be, work with our communities, to gain a common understanding. So some patients in our intensive care unit did die because they, to their death, refused to have invasive ventilation.
Yeah, I agree. Quickly, about the next pandemic?
Yeah, I think that we are always prepared for the previous war, and we are always very well prepared for the previous pandemics. So I don't know what's going to be the next pandemics. I mean, if it's a dysentery, I don't think ventilator will be very useful. We're going to need fluids. So, you never know what will be the next pandemics. And I think that what is important to get prepared is to have a good healthcare system. And this is the core of how a community can fight the pandemics.
Okay. More comments?
And maybe testing the hypothesis we have after this pandemic, and especially the interest of CPAP in those patients. We should test in big prospective studies, I think.
And work with countries having billions of inhabitants, right? That's different. Okay, thank you very much. Fantastic.